Welcome to Brain Ponderings. I'm the host, Mark Matson. Today, my guest is Professor David Menon. He's a world's expert on traumatic brain injury, particularly from clinical perspective. He's been involved in a lot of European-wide and worldwide collaborative efforts to understand, characterize, and treat traumatic brain injuries, and with the goal of trying to particularly improve outcomes, obviously, in the short term and in the long term. And one thing that's emerging is that there's a lot of individual variation in recovery. Recovery does occur, but then there may be this later on decline that occurs. So welcome, David. So you're a professor at University of Cambridge, where you're head of division of anesthesiology. You're also one of the, I guess, organizers or head people in this European-wide effort, the Center TBI. Is that right? And so why don't we have you start off with the basics of traumatic brain injury. How many people are affected each year, I guess, worldwide or in Europe or whatever, and what are kind of the range of outcomes?
Yeah, so it depends on whether you include, when most people think about traumatic brain injury, they're considering patients with relatively severe traumatic brain injury who come to a hospital and often are
Yeah.
admitted. But the vast majority of patients with traumatic brain injury have mild traumatic brain injury, and if they pitch up to an emergency room, they are discharged from there. And 90% of the patients who have traumatic brain injury fall into that category. There's still a substantial load. The figures are not that great because those latter patients are not always included in the statistics.
Hmm.
But it's worthwhile thinking about it this way. The cost of traumatic brain injury, the treatment and the consequences of traumatic brain injury probably cost the world between 400 and 500 billion a year. And if you go to the CIA website, which maintains the statistics on this, you can find out what the world GDP is. And it turns out that one in every $200 that the world makes is spent on the care or consequences of traumatic brain injury.
Wow.
So it's also the most important cause of disability adjusted life years in younger people. And in terms of the overall years lived with disability, because many of the patients have been young until now, and we can talk about how things are changing. So far, it outstrips even diseases like dementia, unless you take the really oldest people. So it's got a high mortality ranging in the region of about 1 million or so, but it also has a substantial burden of disability. And now there's this final thing that's emerging, and we don't have good statistics for that, that it may predispose to or accelerate late neurodegeneration. It's been included in the Lancet Neurology Commission on Dementia as one of the epigenetic treatable causes of dementia. And I
Yeah.
think that that's something that's going to explode over the next decade.
And so, right, so traumatic head injury is a risk factor for developing dementia later in life, even if the person experienced the traumatic brain injury, say, during midlife or possibly even earlier. Is that?
So that's certainly the suspicion. Not everyone gets it. We think that it's an interplay of both the exposure to traumatic brain injury, but also genetics. And very roughly speaking, by rule of thumb, with a mild traumatic brain injury, you may only have an odds ratio of perhaps 1.5. I mean, the figures are not that precise because they vary. But if you happen to be APOE4 carrier and you have a severe traumatic brain injury, you have a tenfold chance of compared to the general population. So there's a strong interplay of environmental effects and the genetics of the person.
And that kind of provides some insight, at least at a superficial level, into the mechanisms. Early on when APOE4 was associated with increased risk of Alzheimer's disease, that was back when everybody was focused on amyloid And so, papers would come out trying to explain it based on that. But there's other potential mechanisms. For example, I have to go into a little detail. So there's 3 different forms of APOE, 2, 3, and 4. And they differ just in a couple amino acids. And in those 2 amino acid residues, in E2, there's 2 cysteines. In E3, one of them's a cysteine, one of them's not. And in E4, neither are cysteines. And we did these experiments where we found that, so cysteine plays a very important role in antioxidant systems, like glutathione, one of the main antioxidant systems. There's a sulfur residue when they form. So anyway, we did these experiments where we showed that E2 was very protective of neurons against oxidative stress, E3 less protective, E4 not protective. So that anyway, that's just another potential mechanism, but that's can maybe better link with the bridging TBI and Alzheimer's because it doesn't necessarily involve amyloid at all.
Yeah, so the studies looking at APOE genotype and outcome from acute traumatic brain injury are still a bit sort of difficult to interpret. So there have been candidate gene studies characterizing APOE genotype exactly as you described. And a lot of them have suggested that there's a relationship. We did a systematic review of this must be about 5-6 years ago, and it looked as though overall the APOE E4 possession of an APOE E4 overall across the severities had a increased risk with an odds ratio of 1.4 approximately. But nobody had done a large GWAS study. So about 3 years ago, we published a joint study across TRACK TBI, which is the big NTBI study in the US, and Center TBI, which is our European study, with just under 5,000 patients. And we looked very hard for an association with APOE, and we couldn't find one. And when you go back, you start wondering exactly how these interactions might take place. My sense is that it's very important for subacute and chronic events. Acutely, it may be important, but we need some more robust evidence to underpin that.
Okay. And so when a patient comes to the hospital, how are they evaluated?
Yeah, so that's something that's going to be changing, and coming to an emergency room near you is a new TBI classification scheme, which is being developed under the sponsorship of the NIH and led by Jeff Manley from UCSF, Andrew Maas from Antwerp, and several other people. But the traditional way that patients have been classified is as mild, moderate, severe based on the Glasgow Coma score. Mild traumatic brain injury is a Glasgow Coma score of 13, 14, or 15, moderate 9, 10, 11, or 12, and 8 or less was considered severe traumatic brain injury. There's been a bit of a backlash and a strong protest about this from patients, because what people with lived experience of traumatic brain injury tell us is that if they're classified as mild traumatic brain injury, they're expected to get better, and any residual disability is simply ignored. And at the most severe end of the traumatic brain injury spectrum, severity spectrum, patients with severe traumatic brain injury, particularly in centers that aren't interested in neurotrauma as a clinical driver of their work, patients are often given up on, and people who could have reasonable outcomes or sometimes even good outcomes don't receive the aggressive management that they merit. So that was one problem. The second problem was that the Glasgow Coma score doesn't characterize these patients well. So at the most severe end, if someone has a Glasgow Coma score of 3, they're not opening eyes even to pain, they don't make any sounds at all, and they don't have any motor responses. Now, that might mean that someone has very severe traumatic brain injury. They've got devastating brain injury, but it might also mean that the person is drunk and has fallen over and hit their head and has been knocked out and is not responsive. Or they may have had a peri-injury seizure And following on from that, they are in a post-ictal state and unresponsive. So we need other ways to characterize this. And there is now an exercise underway which will be completed, I would thought, within the next 6 to 12 months to try and bring a little more detail to this. From the clinical viewpoint, we've always used pupillary reactivity as a very important clinical tool, and that's being very formally plugged into the acute clinical management. And at the top end, when Glasgow Coma score is 15 and people are well oriented and obeying commands and eyes are open spontaneously, one little wrinkle might be that they are still not laying down new memories, so they have post-traumatic amnesia. And we know that if post-traumatic amnesia in the milder end of the population persists for more than 24 hours, then the chances of a full recovery are less. And in the more severe end, if patients are still not laying down new memories 56 days, 8 weeks after their injury, then their chances of being independent and surviving with independence is less than 50%. So we've got these rather strong predictors, and we want to start bringing this in. The pupils is straightforward. It's just a question of how we incorporate it, whether it's a single score or not. But when you're talking about post-traumatic amnesia, there are a few wrinkles to sort out in terms of how we acquire that data. But apart from the clinical characterization that I've talked about, there are three other pillars of this classification system. The first of those is blood biomarkers. So we know now that blood biomarkers have been approved by the FDA to rule in or rule out the need for a CT scan. And the ones that are hitting prime time are GFAP, the glial fibrillary acid protein, and UCHL1, both of which are released into the bloodstream after an acute brain injury. And for a long time, some European protocols, particularly in Scandinavia and France, have used S100B, another astrocyte protein, as something to help make management decisions. But we now know from studies like Center TBI and Track TBI that these are also prognostic. The difficulty is, of course, that these have been run by and large as research assays, and it isn't like ordering a troponin. You've got to say that this is the value that's come from this platform. Though there are now some FDA and CE marked platforms, Abbott, for example, Biomera in Europe. And I think within the next few years, we'll be using this routinely to characterize our patients. Probably looking at thresholds of when patients become CT positive and when the outcome is more likely than not to be unfavorable.
And these proteins that are normally inside of astrocytes, they're released into the, I guess, CSF and blood. Of course, with TBI, there's often disruption of the blood-brain barrier. What about neuronal proteins? Do they also predict the severity or?
Yeah, so UCHL1 is a neuronal body protein, and then there are two axonal stroke dendritic proteins that are in common use, at least in research, and that's neurofilament light and total tau.
Yeah.
I mean, there's also an interest in phosphorylated tau, but that comes from the dementia amyloid deposition story. And again, I think that will be important. So I think these blood biomarkers will allow us to quantify it. And if I go back to the example I gave you, the patient who's got a Glasgow Coma score of 3 is deeply comatose. What we've done in the past is to do a CT scan. If they had a devastating brain injury, large hematomas, then we knew they had a devastating brain injury. But if the CT scan was normal, there are two possibilities: that it is normal, or there's diffuse axonal injury, which is simply not being picked up by the CT scan. But now, once you have the patient with a normal CT scan, if their blood biomarkers are trivially elevated or not elevated at all, you can rest easy that it's unlikely to be a severe traumatic brain injury.
Yeah.
Whereas if they're markedly elevated, we now know that both for mild traumatic brain injury and for severe traumatic brain injury, we can actually use those as triggers for asking for an early MRI to quantify the amount of diffuse axonal injury. So we now have then the clinical characterization, which is getting a bit more tight and well characterized. We have the blood biomarkers, both neuronal and axonal neuronal and astrocytic biomarkers, and a little more quantitative neuroimaging and incorporation of MRI as well. But then the final thing is the modifiers sort of pillar to this. We know that in addition to what the impact brings to the injury, it's also important what the patient brings to the injury. So that's a phrase coined by Jeff Manley, and I think it's very apposite. And what that means is that someone who comes to it with minimal cognitive impairment or age-related cognitive decline is going to have less reserve, and as a consequence of that, have worse outcomes. More importantly, diagnostically also it matters, because we know that both GFAP and NFL, neurofilament light, have age-related increases, even in healthy aging. So we need to have age-related, age-appropriate norms. And finally, if someone has pre-existing dementia, we know that traumatic brain injury accelerates their course of deterioration. But we need to tie into our diagnosis and prognosis the rise in biomarkers that are associated with dementia and amyloid deposition and so on.
What about, David, what about general physical health? Obesity, or is the person in physical shape? Do they have insulin resistance? Do any of those have an
So,
impact?
yeah, so we know that pre-existing cerebrovascular disease is very important. And now we have from a combined paper from Center and Track TBI, a recognition that frailty, independent of age, is a really important driver of outcome in traumatic brain injury. These are not surprising. It's what you would
Yeah.
expect, but this is the first time we've had the evidence. So there's a list of comorbidities that we will be able to almost have a tick box series for, that people can go through and make sure that these things are there. And then social determinants of health are also important. And it may be something as simple as person who doesn't speak the language that's most commonly used. So if you have someone who's a Spanish speaker in a predominantly English speaking hospital, or someone from the Far East, particularly an older person who's not fluent in English but speaks Cantonese, there's a huge disadvantage to them in terms of engaging with rehabilitation. So these social determinants of health are also receiving a lot of attention.
They're under more stress.
Correct, yes.
Yeah, yeah. And okay, so depending on, what caused the blow and, where the head was hit, intuitively you would think it's going to make a difference where most of the brain damage are. But you also mentioned this like shearing of axons, which I guess that could occur at a distance from. Can you talk a little bit about, are there any brain regions that tend to be affected more or less?
Yeah, so I think we should start off by saying that for the injury to be restricted to the site of impact is very unusual.
Okay.
What is important are acceleration, deceleration injuries, which have two or three consequences. The first is when you accelerate and decelerate, and there are graphics on the web in many places, the brain moves inside the skull because it has different density and different inertia, and as a consequence of that, it impacts on the inside of the skull. And one of the disadvantages of us having relatively evolved brains with lots of sulci and gyri is it fits into the inner surface of the skull, particularly the base of the skull, with quite a lot of sharp edges where it's nestling these gyri and sulci. So any movement of the brain independent of the skull causes contusions, bruising on the surface of the brain. More deeply, because the white matter and the gray matter and the deep gray matter, so the cortex, the white matter inside with the connecting fibers, and then the thalamus and basal ganglia all have different densities. Any movement, particularly rotational movement rather than linear movement, causes shearing injuries. And you can have large shearing injuries which result in hematomas, or you can have smaller shearing injuries which damage both small blood vessels, microvessels, but also damage axonal pathways. And such axonal and microvascular injury is pervasive in patients, particularly when they have severe traumatic brain injury, but probably also occurring in milder forms of injury. And in patients with more severe injury, it is the primary driver of outcome, apart from surgical lesions which compress the brain. As to which parts of the brain are most vulnerable, well, to the shearing and the acceleration, deceleration injuries, it depends a little bit. So if you've got an elderly brain and the brain is shrunk compared to the skull, movement of the brain inside the skull will tear the veins that bridge from the cortical surface to the venous sinuses on the inside of the skull. And with relatively small velocities, you can have tearing of these vessels and formation of subdural hematomas. But when you come to axonal shearing, then the middle parts of the brain are both more what we call a cone of vulnerability. The white matter going down to the corpus callosum and then eventually into the brainstem are regions where there's particular risk of axonal injury. And depending on how severe it is, it can cause relatively minor deficits, going all the way to unresponsive coma that patients don't emerge from, and they wind up being in a vegetative state. So there's a whole spectrum of injury.
And so then what are the course of the treatment? So you mentioned, that our brains completely fill the skull, so there's not much room. So if you get damage to microvessels or you get inflammation, that's going to cause swelling, right? And that's going to make things worse.
Yeah, so the normal pressure inside the skull when you and I are walking about is probably close to zero. And even when you're lying down, it's probably single figures in terms of millimeters of mercury. And the reason blood gets into the brain is because the blood pressure, the mean arterial pressure, is off the order of about 90 to 95 millimeters of mercury. So there's a driving pressure of about 90 millimeters of mercury providing perfusion to the brain. But when there's brain swelling, I should also say that the brain autoregulates very well and can tolerate reductions in blood pressure without having ischemia, or increases in blood pressure without leakage of fluid from the intravascular compartment into the tissue. When you have brain injury, the swelling in the brain can increase intracranial pressure because this is a closed box. It's filled with incompressible material. Initially, when there's brain swelling, some of the compensatory mechanisms can mitigate that. So some of the cerebrospinal fluid, which is in the intracranial cavity, can go down to the subarachnoid space. Some of the blood vessels get squeezed a bit. But those are very rapidly exhausted, those compensatory mechanisms. And then the pressure rises exponentially. And this rise in pressure and the mechanisms that cause it have two consequences. In terms of the plumbing, having a very high pressure inside the head means that blood can't get in. So you don't tolerate relatively small reductions in blood pressure. So while you and I will tolerate without significant ischemic damage mean arterial pressures of say 50 or 60, generally the patient who has a traumatic brain injury and raised cranial pressure cannot tolerate cerebral perfusion pressures of less than 60. That means mean arterial pressure, which is driving the blood, minus the intracranial pressure. We tend to speak about brain swelling causing significant pressure inside the skull when the pressures get above 20 or so. So when you think about it, you don't have much room for drop in blood pressure, because if your mean arterial pressure is 80 to 90, which many of us will run at, then you're just at the edge of what the brain is going to tolerate. When you drop below that, we know that the outcomes are worse, and there have been some very good mathematical calculations of how these drops in cerebral perfusion pressure below the lower limit of autoregulation worsen outcome. At the upper end, if you have, just like there's a sensitivity to a drop, the brain blood vessels no longer have the capacity to keep all the fluid inside their vessels. So when the blood pressure rises too high, then you can get increase in edema. So there's a very fine balance to be had of maybe a few tens of millimeters, much less than the 100 millimeters or so that you and I can tolerate in terms of the range of blood pressure. But the second thing that happens is that at the microvascular level, the fluid that's accumulated around these microvessels can shut down the microvessels, or you can get microthrombi within these vessels. So the microvasculature is less efficient at transferring oxygen to the tissue, a phenomenon that we've referred to as the perfusion utilization mismatch. And you get diffusion hypoxia. So when the tissue is not getting enough oxygen, pushing up the blood pressure on its own may not help. And we have to find ways to reduce the perivascular edema and perhaps, though the jury is still out on this, increase partial pressure of oxygen so that there's a higher diffusion gradient. That last question is being addressed in two large phase 3 trials, the Bonanza trial in Australia and the Boost 3 trial in the US. And in the next 3 or 4, probably in the next 2 or 3 years, we'll have good evidence as to whether targeting brain tissue PO2 results in better outcomes than just targeting intracranial pressure on its own.
So you kind of the very important thing is to measure the intracranial pressure and keep it down.
Yeah.
And then what about cooling? I remember that there was a lot of interest in the acute phase of either a stroke or a TBI, actually cooling body temperature, brain temperature, with the idea being there'll be less damage. Is that something that's done or not?
Um, yes and no is the answer. So generally, the evidence from the phase 3 trial suggests that it's not beneficial. And there's at least one trial, large trial, European trial, that suggests it may cause harm.
Hmm.
There are 2 or 3 things that you've got to think about there. The first is that these trials have generally used it across the board in patients who have brain injury or with very little intracranial pressure elevation. It's been used as almost the first or a very early treatment that's deployed. And I don't think that that's wise because hypothermia has its own problems, both systemically and in the brain. Systemically, it causes cardiovascular depression, increases the risks of infection. It's an immunomodulatory insult. And in the brain, if the brain gets cold, it's okay, but rapid rewarming after that is almost worse. Well, not almost, it is worse than never having been cooled in the first place.
Interesting.
So,
Huh.
the present consensus has been that we should avoid hyperthermia, and when you cool patients, it's only in the most extreme situations, and not all centers use it. We do use it in Cambridge, and we go down to 33 or 34 degrees core body temperature, but that's a local variation. And some centers in Europe will also use that, but many centers have stopped using that as a routine management. All of us would try and keep the temperature within normal limits. One little twist to that is there's been a lot of interest in having local cooling of the brain, either by cooling the carotids or some people have used balloons inside the nose
Hmm.
that put refrigerant gases almost and cool the substance of the brain without whole body cooling. Now, whether that can be achieved or not is the jury is still out on it. But if you could get selective cooling of the brain, at least the systemic side effects of cooling might be something that can be avoided. And that might be quite attractive, but we'd have to run the trials again to see whether that works or not. And we use it very simply because cooling will reduce intracranial pressure. And if the intracranial pressure rises above 30 or 40, the danger is that you can get herniation, compression of the brainstem, and death. And in that desperate situation, to quote William Shakespeare, desperate diseases are cured by desperate remedies, but you have to match the desperation of the remedy to the desperation of the disease.
Yeah. And are there in the acute phase, we'll move to the chronic phase and recovery, which I think is very important. But are there any drugs that are given in the acute phase that help?
Not, not really. I mean, there's lots of treatments that are deployed to reduce intracranial pressure. So we use hyperosmotic agents like mannitol and hypertonic saline, typically starting at 1.8 and going up to some people use 20% saline. And the reason that works is those bits of the brain where the blood-brain barrier is intact will not see the sodium going into the tissue spaces. So some fluid is sucked out of the brain and reduces intracranial pressure. We use reductions in carbon dioxide because the intracranial capacitance vessels are exquisitely sensitive to pH, and carbon dioxide is a diffusible acid. So if we hyperventilate people, you can get some vasoconstriction. You have to be careful though, because as any plumber worth his salt will tell you, If you make the pipe smaller, you'll also reduce flow through it. And unless the intracranial pressure is high, generally the effect of hyperventilation is to reduce cerebral perfusion. And we've shown those with positron emission tomography studies. There are drugs that are used to prevent epilepsy and reduce metabolic demand. We use sedative drugs mainly to control intracranial pressure. So these treatments are all targeted intracranial pressure rather than any primary pathophysiological mechanism. And we have at present no medications in the acute phase that address mechanistic processes that worsen brain injury. What we're dealing with is the physiological consequences of those mechanisms.
All right. So then in patients that recover, you know, you mentioned the different gradations, the Glasgow score and the kind of revised approach. So have studies been done where, you know, people in those different bins have been followed up for many years?
Yeah, so there are two things to say about that. One is that clearly the outcome depends on the severity of the brain injury, the Glasgow Outcome score, whether you've blown a pupil or that you had an unresponsive pupil, which suggests that there was brainstem injury. And at the more mild end of the spectrum, how severe the injury was and what symptoms you had. But what we have changed our focus on, so classically, when we looked at the Glasgow Outcome score, we used to reflect on whether patients were dead or dependent, which was whether they were dead, they were in a vegetative state, or they were severely disabled. That is, they were not independent outside the home. And that was deemed to be an unfavorable outcome, whereas a favorable outcome was either fully recovered, but going all the way down to being disabled, but independent outside the house. So that was the dichotomization, dead or dependent, but versus alive and independent. There are a few nuances to that now. First of all, if you've had a very severe brain injury and you've had large hematomas, you've had 2 or 3 episodes of neurosurgery, stayed on intensive care for 3 weeks, then that dichotomization is entirely appropriate. But if I get knocked out because I was involved in an accident while I was riding my cycle, then I went, having recovered, to the emergency room. If someone told me, your recovery when you're going to be disabled but independent is a favorable outcome, I'd be very cross indeed. So this concept of complete versus incomplete recovery is something that's gaining currency. So the Glasgow Outcome Score Extended, which is the ordinal score we use for looking at the outcome after traumatic brain injury, the top end of it is upper good recovery, where patients are back to doing everything they were doing before. So this is a functional classification. They may still have symptoms, but it doesn't interfere with their daily life. Functionally, they're back to being what they were like.
And
And
is there a certain time window for that recovery period that with?
yeah, so there is. I mean, if we used to think that most patients who came to the emergency department had a traumatic brain injury and were well enough to be discharged from there, the vast majority of them make a very good recovery. But at 6 months, even those patients who are discharged from an emergency room, about 50% of them are still symptomatic. They still have an incomplete recovery. They don't get to a GOSE of 8. They will continue to recover over time, and maybe by a year or 2 years, those proportions are much more favorable. But when you look at more severe traumatic brain injury, we used to look at outcomes at 6 months, and typically about 50% or more, maybe up to 60%, had either died or were not independent. They were dependent, they were dead or dependent. And there was a lot of nihilism because of that. But what has emerged in the last 10 years or so is the realization that these patients continue to improve for many years afterwards. And in some trials, for example, the trial of decompressive craniectomy, which I should have talked about for raised cranial pressure. So we should probably just reflect on that. When the intracranial pressure is refractory and high, and the worry is that this will kill the patient,
Right.
one of the interventions that we can make is to remove a part of the skull, allowing the brain some room to swell. And we know that this increases survival, but in the short term, what the suggestion was that it may worsen for functional outcome. There are some nuances to that about how you do the operation, whether you divide the forks in front and so on. But suffice it to say, the two trials that were conducted, one is the DECRA trial from the ANZIX group in Australia and New Zealand, and the second was the Rescue ICP trial that was driven from Cambridge. The ANZIX trial used decompressive craniectomy as a relatively early intervention and found that patients didn't do better with the decompression, whereas the Rescue ICP trial, it was done to rescue refractory intracranial hypertension, but that wasn't responsive to other measures. And there was increased survival, about a 20% increase in survival. But of those 20% at 6 months, half of them had unfavorable outcomes and half of them had favorable outcomes. So these are patients with the most severe injury, but still we were rescuing half of them. But what we also found was that if you follow these patients up for a year or 2 years, the number of people who become functionally much better keeps increasing, so that you have to, in these patients who've got a decompressive craniectomy, realize that the fat lady hasn't sung until you get to 2 years at least. It might be much longer than that. So those are nuances that we were not aware of. Now, it's a challenge for research studies and also for clinical care, because following patients up with no intervention available to audit our outcomes is going to be challenging. Our hope is, though, that we will start to have treatments that we can deploy over that period, and this will start becoming worthwhile for patients to come back to hospital.
And
So,
age is a factor in everything you've said so far. That is, if the person's older, it's less likely they'll be recovered by 2 years compared to someone younger.
Definitely age makes a big difference, but there are two ways to look at it. One is to say that chances of a complete recovery, or as good as recovery as you might expect in a young 15, 20-year-old person, are not going to be achieved by a person who's in their 70s, because their cognitive and brain reserve is low. They're likely to have had other comorbidities. They may be frail and so on. But the flip side of that is, if these are patients in their 60s and 70s who are independent, unless we aggressively treat these patients and find treatments to prevent worsening, there's a personal cost to this. Patients become disabled, they become dependent, and there's a societal and familial cost to this. Instead of having a grandfather who was supportive of the family, suddenly they become a problem both for themselves and for their families and for society as a whole. So the feeling that we shouldn't be treating these older patients aggressively, particularly at the milder end of the spectrum, is something that's increasingly thought not to be the right thing to do. And there's a study happening in the US, the track Jerry study, looking at traumatic brain injury in geriatric patients, very conservatively described as patients over the age of 65, and I'm over the age of 65. So I hope that that kind of ethos makes sure that if I'm rescuable, I have the best possible rescue from a traumatic brain injury. Clearly, if I have a devastating brain injury, my chances of going through a period of rehabilitation, making that long-term recovery over 2 or 5 years that we talked about earlier, is less likely.
Yeah.
It comes down to how much reserve you have, not just in the brain, but also physiologically in the rest of the body. If you're a fit, young, marathon running 70-year-old, that's fine. And you may still have the physiological reserve to get through that process. But if you're 55, but you have metabolic syndrome, you're obese, you have coexisting coronary artery disease, cerebrovascular disease, perhaps COPD from a lifetime of smoking and diabetes, then despite the fact that you're relatively young, your outcome is still going to be affected by that.
Next week on my podcast, I'm going to have Jakob Stern to talk about cognitive reserve in relation to brain aging and dementia. But it's an interesting concept that we can, just like you mentioned with exercise, right? If you get in shape or build up your muscle mass during your life, you're less likely to become frail.
Correct.
But yeah, so anyway, and then can you talk about, before we went live today, we briefly talked about chronic traumatic encephalopathy, CTE, which we hear a lot about from, I guess, first American football players, but I think there's also very recently been some rugby player
Yeah,
studies.
there
And
has, and
contrast
also,
that with, repeated small subconcussive hits versus, one major hit and then recovery.
yeah, so both concussive, repeated concussive hits and probably subconcussive hits create a burden of pathology in the brain. Exactly how much is needed to do it, what is the dose of that kind of milder traumatic brain injury that is pathogenic, is the jury is still out on it. But what we do know is that patients, that individuals, I should say, because at that stage they're not patients, who've sustained repeated brain injury either in the armed forces or in contact sport, tend to have late neurodegeneration. Chronic traumatic encephalopathy, classically or canonically seen as a tau-mediated process, has received a lot of attention in the context of the NFL.
Yeah.
But clearly, when you look at the broader spectrum, many other kinds of neurodegenerative pathology, including amyloid deposition and alpha-synuclein and TDP-43, have also been reported. And the other phrase, as we discussed earlier, from the Connect TBI collaboration across Glasgow and Penn and involving many centers, is trauma-related neurodegeneration or trend, recognizing that there are many pathologies. And Willie Stewart and Doug Smith have been accumulating a cohort of investigators who are looking at this in more detail. And the pathology, both for this and for acute traumatic brain injury, is critical because our insights of what happens in traumatic brain injury in the acute and the chronic phase comes from the neuropathology. So why is that important? Well, it's important because if we demonstrate this neuropathologically, we now have the opportunity using molecular imaging to demonstrate this in life. So we've used PIB PET to demonstrate amyloid deposition as neuropathology has shown within hours to days of acute severe traumatic brain injury. And David Sharp's group in London have used tau PET to demonstrate tau deposition at late time points after many years after traumatic brain injury. And PK195, which is a mitochondrial marker, probably not very as specific as we would like, but to show neuroinflammation up to 17 years after traumatic brain injury. Now, these are all hallmark pathologies that are being addressed in the context of late neurodegeneration. And now treatments are emerging for it. The monoclonal antibodies against amyloid are probably the most topical of these. But if we recognize patients with traumatic brain injury as a particularly high-risk group, then it's not a question of what neurodegeneration can do for traumatic brain injury, but to quote John F. Kennedy, what traumatic brain injury can do for the process of neurodegeneration, because these are captive populations of patients we can seek out and identify with appropriate molecular imaging which ones of those have early deposition of these pathogenic proteins and include them in trials. The endpoints are much more quick than you might expect in trials of chronic neurodegeneration. So there are now treatments available which we can deploy in this population. And I was saying previously we'd just be bringing people back to audit our outcomes and perhaps for research. But now, or at least in the next 5 to 10 years, we will have trials looking at treatments addressing these processes and perhaps trying to mitigate them.
And what about the energetic status? We've done a lot of work on intermittent fasting, the effect of fasting on the brain and its vulnerability with aging and various animal models, and actually have some data in a paper under submission in humans now. And those data suggest that a natural ketogenic state, fasting, seems to be neuroprotective. And when I was at University of Kentucky, I don't know if you ever came across Byron Young.
Yes.
Yeah, and he, we had conversation. This is a long time ago. This is in the 1990s. We had conversations about this, nutritional status, and he was a big proponent. You've got to keep glucose levels up and so on. And I was saying, well, glucose can actually lead to a lot of oxidative damage compared to ketones. And so we had this. So what's done in the clinic, and are there any clinical trials addressing something, manipulating the energy substrates?
Yeah, so as part of our clinical monitoring in patients with more severe traumatic brain injury, we place microdialysis catheters in the brain. And we used to have 20, 30 kilodalton catheters, but now we have catheters that can go up to 100 kilodalton molecules and bring them through. We use it for two reasons. For research that allows us to look at mediators that are being released in the brain with the time profile that's much more detailed than we would get from other sources. But it also allows us to look at extracellular glutamate, which is an excitatory amino acid, glycerol, which is a marker of cell membrane breakdown, but very critically at lactate and pyruvate levels and the lactate pyruvate ratio. So we can monitor the energetic state of the brain using the microdialysate and also using brain tissue PO2 monitoring, which is also routine clinical monitoring now. The other molecule that we can measure is brain glucose levels. And what we find is probably because of the microvascular compromise, brain glucose levels drop pretty substantially. And we know that tight glucose control, 4 to 6 millimoles. Now, well, what's that? 80 to 100 milligrams, which would be seen as good glucose control in other situations, can result in energy crises in the injured brain. This is work from Paul Vespa.
Have you also measured the ketones to see, because if it's mainly due to a microvascular problem, you'd also expect a reduction in ketone levels?
So no, not ketones. A lot of the ketones are lipophilic. So generally, because the microdialysate picks up most of the hydrophilic molecules, we don't see. So some of the sedative drugs like propofol, even though we know it's getting into the brain because patients are asleep, it's very difficult to see that in the microdialysate. But there is an increasing, so I'll just deal with the glucose story. So while what you say is absolutely true, both through causing oxidative damage and glycated end products and so on, it can cause damage. What we know is that low brain glucose levels, and these are less than 0.5 millimoles, 0.5 millimoles, about less than 10 milligrams percent, is a problem because it tends to trigger episodes of spreading depression, and pushing up the brain glucose can prevent that. Having said that, we don't want the brain glucose to get high, but we very rarely see high brain glucose in patients who've got significant traumatic brain injury. But what we do know is that molecules such as ketones and lactate may be preferentially useful fuels in that situation. And Chris Giza in UCLA, and to some extent also Paul Vespa, have been championing this, Mayuri Prince as well. And then in Europe, Mauro Oddo, who works in Switzerland, has been talking about using lactate. Why is that important? Because first of all, it talks to the evidence you were talking about, ketone bodies and brain health. But the second is that the monocarboxylic acid transporters tend to get upregulated in the microvasculature. And you can actually manage to get some of these substrates into the brain without having to push up the blood glucose with all of the other consequent attendant damages. Now, we need a trial of that, but that I think is something that would be quite attractive.
Okay, so prevention and risk reduction, we haven't even talked about it, right? But seat belts, although you said, so this acceleration, deceleration thing doesn't necessarily, can prevent a blow, but I mean, if you hit something and stop suddenly, that may be enough to cause a TBI. But anyway, so wear a helmet when you're riding bicycle. As you mentioned, so most TBIs are in younger, very active people, particularly males, I think, who are a little more daredevil-like.
So yes and no. So the first thing is that certainly worth wearing a seatbelt, because the acceleration deceleration that you get from the whiplash is going to be much less than if you're not wearing a seatbelt and you travel and you impact the windscreen. Then all bets are off. But the second thing that you said is no longer true in Western civilizations, in first world countries, in high income countries. The largest and growing population of patients who have a traumatic brain injury are the elderly because of falls. And they're very badly served by our current pipelines of care. Now, in low and middle income countries, it's still young people having road traffic accidents and so on. But even they, as they become more urbanized and move towards our sorts of economy, are seeing an increase in older patients having a traumatic brain injury. So the so just to illustrate that, the traumatic coma data bank in the US probably collected patients in the 80s and reported on it in the early 90s, late 80s. The median age of patients in the ICU was 25 years. In Center TBI, which is a big European study we did, which was we recruited between 2013 and 2017, the median age in the ICU was of the order of about 50 years. And that's the median age. So many of these patients are older because, first of all, older patients are having injuries. And second, we are realizing that they're not non-rescuable. These patients can have good outcomes. And we bring patients in. Some of them are brought in because they have comorbidities as well, and we want to keep a close eye on them. But certainly in the hospitals where I work and in the healthcare systems that both of us enjoy, it's the older patient who's the growing sort of customer who comes to the emergency department with the TBI.
And then as far as inflammation goes, there's a lot of biomarkers for inflammation, pro-inflammatory cytokines like TNF, interleukin-1 beta, and so on. But I assume these have been followed in cerebrospinal fluid or blood even. Are there systemic? Is there like systemic inflammation that occurs following a TBI? And
yeah, there's definitely systemic inflammation, and we know that systemic inflammation will worsen brain inflammation in turn. And we have really good handles on brain inflammation from CSF levels, from neuropathology, but also from microdialysate. And we can look at the time frame over which and the trajectories for these canonical inflammatory markers, including IL-1 beta, IL-6, and so on, and TNF as well. There have been a few small trials. So there's been a trial of anakinra from Cambridge, Ed Al-Helmi and Peter Hutchison, did an experimental medicine study and showed in a randomized study that anakinra IL-1RA, soluble IL-1RA, actually reduced downstream cytokines. So it did what it said on the tin. It was an anti-inflammatory intervention. There's a lot of interest in using TNF antagonists, also IL-6 antagonists. And we've been emboldened in the latter because of the success of tocilizumab and sarilumab in COVID, because we now know we can deploy these drugs in critically ill patients without causing harm, or we can mitigate the harms from immunosuppression.
there have been a lot of patients that the TNF antibody therapies are pretty widely used for rheumatoid arthritis and maybe
Correct.
And and some of those people are going to have a TBI. Have that population been looked at and compared to age-matched, control?
Yeah, it has been looked at. There's no conclusive evidence there. The analyses are probably not as rigorous as they should be. There's been a vogue. Maybe I shouldn't be as dismissive as that. There've been reports of people using perispinal Entrecept, TNF antagonist, and suggesting that it may make a difference in chronic symptomatic TBI, people who have consequences of having had a TBI some time ago. But I think, again, over the next 5 years, both because we have these biomarkers and we can de-risk drug development, some of these anti-inflammatory interventions will be looked at in great detail, not just in the acute phase, but also chronically. And we know, so in the GWAS study we did, we looked, a 5,000 patient study is underpowered for GWAS, but we also looked at all of the candidate genes that have been reported on before with very rigorous corrections for multiple comparisons. And it's worth noting that the only one that survived all those corrections was an inflammatory gene. It was mannose-binding lectin-2, and polymorphisms are associated with worse outcomes. So it looks as though inflammation is a key player, and I think we'll hit prime time pretty soon.
Okay, and finally, how's funding for TBI, and how has Brexit impacted or not your own personal funding?
Yeah, so there are two parts to this. We felt very much like the Cinderella of neurological disease until about, say, 15 years ago. And then the European Union, CIHR, Canadian Institute for Health Research, and the NIH came together to construct what's called INTBIR, International Initiative for Traumatic Brain Injury Research. And the first generation of INTBIR studies, which were coordinated, used common data elements, which had been produced by an NIH initiative to bring together a whole host of studies with funding up to about $100 million, with 35 to 50,000 patients with registry level data, and probably about 10,000 patients with really granular data. And that has produced a huge amount of evidence, both in terms of description of the disease process, the pipelines for management, and also comparative effectiveness research. Now, what's happened is that INTBIR has transformed into a investigator-driven organization, which is currently jointly coordinated by Ramon Diaz-Arastia from Penn and myself. And we had our General Assembly meeting with the support of the NIH in January this year. And the aim is for us to replicate the success of the first cycle of INTBIR studies, but looking for funding in a much more investigator-driven way. But we know from talking to the funders that they're very keen to look at collaboration between different funders. So I think that
That's good.
our aspiration is that over the next 5 years that we create a $500 million pot for research in TBI. Now, Brexit, now that's a thing. It actually disrupted research funding pretty substantially, but now the European Union and the UK have joined together, and we are part of the European Union funding program again. We contributed to it, we can draw on it. And as we speak, we have a couple of grants that are going into the EU funding mechanism. So things are a bit better now.
That's good, because I remember when Brexit first happened, there was, a lot of uncertainty because a lot of UK scientists and clinical investigators had funding through EU funding sources. But good, I'm glad that is getting worked out.
Yeah, so we missed out on one cycle of funding, I think, but better late than never. So
yeah. Okay, David, thanks for your time. I don't think I've met you in person or virtually before, but I'm happy to meet you. Actually, when I was leaving University of Kentucky is right when a guy named Ed Hall had come, and that was when, free radicals explain everything, right, in the brain disorders and trials of antioxidants, or at least free radical scavenging antioxidants. It's the kind of thing, they seem to be effective in animals, but clinical trials, but so anyway, yeah, so I've had, and talking about funding, it was interesting. So my mentor at University of Kentucky was a neuropathologist named Bill Marksberry.
Mm-hmm.
I don't know if you ever came across him.
No, I didn't have the privilege.
Very well-known scientist working on Alzheimer's mainly, and so the state he knew a lot of the state senators or congressmen, right, in the state legislature, and so the legislature passed a bill that 50% of the money from drunk driving and speeding tickets would go to spinal cord and head injury research. And so I remember that Christopher Reeves, remember him, Superman?
I do. Yep.
Right, and he had a spinal cord injury that paralyzed him. He got thrown off a horse, and he was there. He did a lot for raising awareness and funding for that. But so that's kind of a very rational type of funding, right? If you have this problem, accidents are caused by drunk drivers speeding, that some of that money can go to help the people, affected by it.
Yeah. So we were aware of the Kentucky law and the funding mechanisms, and I tried very hard to persuade legislators in the UK that 50% of the income from moving traffic violations, which I think was the phrase that was used in Kentucky, unfortunately with no success. But we'll keep trying because that's a good model to adopt, I think.
Well, you need a famous person that, the spinal cord injury, if you lump them together, maybe it's easier. I don't know.
Yeah, so that's very true because spinal cord injury patients and their families are very much more articulate and
Yeah,
much better ambassadors for their disease. But I think it's up to us as clinicians and scientists to make sure that the less articulate patients who've suffered a brain injury and are less able to fight their corner are not neglected. And we have made it a point to talk to legislators in the UK, particularly. And recently, you were asking about funding. The UK has funded a national platform with $10 million for all clinical research, which I lead here from Cambridge, and they've committed to providing more funding, basically because of those interactions with the all-party parliamentary group on acquired brain injury. So I think we have a job to do, and we need to do it well
yeah,
to actually speak for those of our patients who can't speak as well as we would like for themselves.
I agree. Okay, David, thanks a lot.
Lovely chatting with you, Mark.
I hope you have a good spring.
Great. Lovely. Thanks.
Bye.